I believe next speaker that we are waiting for, Professor Dr. Esmat Hegazy. She is a professor of anesthesia in Cairo University, and recently she is appointed as the head of the anesthesia of the obstetric and the gynecology unit. Tonight, she is going to speak to us, and the next lecture is actually very interactive. So she's going to give you some questions, and she's waiting for the answer from you. It's going to be few setting of question and answer, and just head up now and get your coffee. And we need to listen the lecture very carefully, and we need to answer. You will answer in the chat box, because she's going to give us some quiz, and it is not exam, but a little bit more or less. And thank you. Professor Esmat, all yours. Thank you.
Thank you, Dr. Saad, for your generous introduction of myself and my lecture. And as you said, it's going to be an interactive one. So let's please feel free. We will have pauses in the lecture. I will present the case, and at certain pause, I will ask my colleagues to share if they need to ask for a patient any investigations or anything. Welcome again and good night. I'm Dr. Esmat, and we will start, inshallah, our case. Let's start by this one, which is the goal of all the anesthesiologists and eventually all the obstetricians. Actually, really, the delivery of an infant in the arms of a conscious and pain-free mother is one of the most exciting and rewarding moments in medicine. Yes, I do agree with Mr. or Dr. Moir, and we will see if we can deliver to our patient this special and crucial kind of care, because she had a very complicated past history, past medical history, as we will see during the this interactive session. And I hope that we can, all of us, it's a teamwork, we can agree about an anesthetic plan that it will eventually give us this picture for a happy, healthy mother and baby at the end. So allow me to start, please. Okay, the condition started in our PEC, pre-anesthesia clinic, by a 36 years old lady. She came to our PEC in beginning of April 2019. Her weight was 121 kg, height 173 centimeters, so with a body mass index of 40.41. She was obese. She was scheduled for an elective cesarean section after 10 days. Actually, her obstetrician, she has took an appointment in our pre-anesthesia clinic to see the patient because she has such a complicated past medical history, as we will discuss in the few coming slides. And she wanted to give us 10 days before her elective cesarean section to, if we want to ask for more investigations apart from the routine ones for cesarean section. And someone will ask me why she was scheduled for a cesarean section, why not to try normal labor? Actually, this indication was both, one from the patient and one from her obstetrician. From the patient, it was a patient request, and from the obstetrician, because her obstetrician decided that this is a precious baby. She was prima gravida, and with all the medical history that we are going to discuss, she was scheduling or identifying this baby as a precious baby, and she wanted to schedule her for an elective easy cesarean section. So let's start our conversation with the patient and her data. And we are now, let's everyone imagine, we are in the pre-anesthesia clinic, first time to interrogate and ask this patient. So the patient was having a horrible car accident at 2006. She had multiple fractures in the cervical vertebrae, for which she had done a cervical fixation with a fixation of titanium plates in the cervical vertebrae. Also, she had from the same accident many level lumbar prolapse and bulging, and she was a candidate of chronic pain, chronic back pain. Again, she had fix that started immediately after her accident. For that, she took a treatment, anti-epileptic treatment, until 2015. In 2015, her doctor, after doing for her an EEG and also MRI for the brain, he decided that she could stop the anti-epileptic drugs. And when we asked her in the pre-anesthesia clinic if she ever got any seizures after stopping the drugs, she said she had no more seizures after her doctor decided to stop the anti-epileptic drugs for her. So this is the data, and we will still go on with more complicated history. On February 2018, the patient had a malignant thyroid nodule for which she undergone total thyroidectomy. She was on replacement therapy by L-thyroxine. Then she had a 1GA, and this is a clue because after that we will ask how we will anesthetize this patient, GA or regional. So this is a clue. She had a gastric sleeve surgery on May 2018. On August 2018, which is 6 months after her thyroidectomy, the patient had a recurrent thyroid nodule. So what she did for that one, she started also to have a change in her voice after she recognized the recurrent thyroid nodule. So this could alert us that it may be a malignant nodule or invading one of the vocal cords. It's one possibility that came to our mind in her first visit to our PEC. However, she did not seek any medical advice for that nodule because she wanted to finish her pregnancy and to have her baby girl without any interference, without taking any medication. She was afraid that if she seeked medical advice, even if she do FINA, if she do final needle aspiration for the recurrent nodule, if it was found to be malignant, she said, I don't want to take any medication. I don't want to take ionized iodine or anything because I want to finish this pregnancy and have this baby no matter what. Actually, she was a very poor patient and we were all wished her the best. She was also, so when she, again, in August 2018, when she found herself pregnant, and this was very short after discovering the recurrence of the thyroid nodule and the start of the harshness of voice. The patient was also have allergic rhinitis, gestational diabetes, and she was adjusted on insulin. She was, of course, a chronic back pain candidate after her accident, and she was also a chronic smoker. Again, we are still in the anesthesia clinic. On examination, as we said, just only remind you, the body mass index was 40.421, which is challenging for both GA or even regional in this patient. She was obese, she was short-necked, and a kind of patient that the neck circumference was very big, really, and you cannot find a neck. And there was, of course, limited neck movement because of the cervical fixation with titanium plates. Thyromental distance, however, was 6 centimeters. It was like a crucial or borderline. Malampathy was 3, and the back was not bad. It was examined in the anesthesia clinic by inspection and the by palpation of the spine. It was not very bad because, thanks God, her obesity was mainly on the flanks. And fortunately, by auscultation, her chest was clear on both sides. If you want me to, at any time of the lecture, to repeat the data, the past medical history again, I can go back for the slides if anyone asks for. Now, after this initial assessment of the patient, this is the first stop now. I'm going to ask you all, we have to share together what more examination and investigation you can request for her. Let's start by examination. You have the patient and her husband in your pre-anesthesia clinic. You did the previous examination, as I told you. So anyone tell me if there is any other examination he would like to perform? Can we have your answers, please? Any more examination for the patient before she will leave your anesthesia clinic? Actually, Dr. Saad, I cannot see the chat box, the answers. Can you please tell me verbally if there is any answer for my question?
Thyroid exam, cardiac exam, neck movement, direct laryngoscopy, airway assessment, direct laryngoscopy, cardiovascular assessment, echo, and I would like just chest X-ray, neck X-ray, nasal endoscopy, thyroid profile, obstructive sleep apnea, CT chest, why she's pregnant, neck mobility, pulmonary function test, loads of textbook, ABG, thyroid scan. That's
Okay.
all stuff coming. Bilirubin. Okay.
Can I have a comment after that? This is all. Thank you for my colleague for the sharing, but all these are investigations. I'm asking about examinations first. Anyone would like to have one more exam for the patient in the anesthesia clinic? And let me give you some clue for the patient back, if he will decide to give any regional. Any more examination he can do for the patient back, apart from inspection and palpation of the spine? Any answers, please, Dr. Saad?
CT scan, neuro exam, neuro complaint, ultrasound, MRI, level of fixation, any scoliosis, lumbosacral MRI, spinal deformity, neuro exam, X-ray. Okay, that's enough now. Thank you.
That's very good, and that's enough. Actually, we were asking about one thing that we can do it easily in our anesthesia clinic before she leaves, which is ultrasound scanning of the back. If we have the machine in our facility, and we do have the machine, so why not to do an ultrasound scan of the back, especially the lumbar spine, which is the area of her chronic pain, so we can easily see the intervertebral disc spaces in the lumbar area, and we can have like a clue about her real damage happened to her lumbar spine after the previous accident. So this is about the examination that we can do. Of course, all airway examination and all those things also were done to her. Okay. MRI, again, yes, we asked for MRI for lumbar vertebrae, because if you even do your ultrasound scan in the PEC, medico-legally, you need a document. And let me tell you that this patient was a VVVIP, actually, here, she and her husband. And so you need, as an anesthesiologist, to document yourself. You need an MRI for the lumbar vertebrae. So everything will be documented, what level, what intervertebral disc space could be left free for our spinal or epidural or CSE or whatever we will do for her. So this is very important. Yes, we asked her to do an MRI for the lumbar vertebrae. Of course, again, and thank you for my colleagues, ENT consultation with direct laryngoscopy of the vocal cords. We need to know if this thyroid nodule, and remember, I will give you another clue. This thyroid nodule was discovered with the beginning of pregnancy, and harshness of voice started quite soon after the discovery of that nodule. So of course, we may think that she has some vocal cord palsy or invasion of this nodule. If it is malignant, it could invade one of the vocal cords. So yes, we need an ENT consultation with direct laryngoscopy for the vocal cords. Again, thyroid function, of course, blood glucose level and everything, and the other routine pre-op investigations like for any cesarean section. Okay, so all these things were asked for the patient to bring with her, and we asked her to come to visit us in the pre-anesthesia clinic again before her elective cesarean section by 5 days, bringing all those investigations together so we can put up the anesthetic plan with the patient and family, which was her husband. She came back. Now, this is the MRI of the patient. Please have a look to it. Take like 2 minutes to read it, and then if anyone wants to send something in the chat box. As we can see here about the opinion, L1, L2, posterior discal bulge, L4, L4-5, posterior discal herniation, degenerative lumbar spondylitic changes with marginal osteophytosis, mild bilateral facetal arthroplasty at L3-4, L4-5, and that was unfortunately the back, all the lumbar area. So again, Dr. Saad, please, I cannot see the chat box. Now I am stopping again. Please, my colleague, tell me if, what about your opinion? Do we have any disk space that we can try spinal for this patient? Any answers, Dr. Saad?
L23, no. L23, that's neuroaxial reconfirmed ultrasound, high spinal, L34, L34, L5S1, L23, Taylor, come on, L34, L23. It seems the majority L23.
Okay, thank you, Dr. Saad.
Thank you.
Then, so we agree that we are expecting that we can find the L23 because it is the only space that has no mention in the MRI to have any abnormality. So we were hoping when we go inside the OR, we will do repeat again for her the assessment by the ultrasound, and we were hoping to find the L23 free for us to give spinal anesthesia. But this is only one of the suggestions. So anyway, before we discuss the anesthesia plan, let's go for her direct laryngoscopy. So this is the direct laryngoscopy. What can we see in this laryngoscopy, please? I have still another 2 pictures, but this one is revealing the epiglottis. Any answers?
Coming. Not yet.
Do you think, my colleagues, that this epiglottis looks normal? Is this the normal thing that we can see when we intubate any patient? Any change?
Edema, nodule, large edematous, swollen, enlarged, edema, folded, edematous, nodules, swollen. Thank you.
Yeah.
So
Thank you
between
very much.
swollen and edematous, folded.
Okay. Thank you very much, Dr. Saad and my colleagues. Yes, actually, this is a very much swollen and edematous epiglottis, and we don't know until now why. Is it only because of pregnancy? Could this be the only cause for the harshness of voice? Let's proceed to the other picture. Now, it was tested by moving the vocal cord. This is the picture of the vocal cords. So, what we see in these pictures? Any answers, please?
Spasm, abducted, adducted,
Okay.
obscured, abducted, cords, abducted, vocal cord edema, obstructed, abducted. Okay, so it means that's difficult. Yeah.
Okay. Actually, we can see in those pictures, to me, it looks like a normal one. because I cannot see any deviation of the vocal cords. They are both symmetrical and both in the midline. So anyway, this is our suggestions. I will give you now the full report of the ENT doctor. Let's read it together, please. No nodule found, no laryngeal palsy, normal symmetrical movement of the vocal cords and larynx. The video was not available from the doctor, sorry. Significantly enlarged lingual tonsil, granulations of the pharyngeal wall. The larynx is swollen and read posteriorly. Both vocal cords are moderately swollen. These findings are compatible with marked reflux disease. So this solved for us the first puzzle. So it was not the harshness of voice like because we have the malignant nodule and it's invading the vocal cord, or there is a nerve palsy of the nerve supplying the vocal cords. So this is the first puzzle was solved for us. This is not malignancy, but yet we still have the risk. She has a very swollen and edematous airways. Again, this is a challenge if this patient will took general anesthesia. One of my colleagues will say why she will be scheduled for GA. Of course, you know, all the anesthesiologists, when we see a patient in the PEC, even if we schedule him and take our consent to give a regional anesthesia of any kind, again, we do reconsent in the same consent that if anything goes wrong, or the epidural or the spinal or the regional cannot be given or failed after injection, because we have an instance of failure, of course. So at that time, we will do what? We will revert to GA. So at that time, if we revert this patient to GA, it really will be a challenging, because if we intubate this larynx, it will increase, we could have a chance of increase the edema and the swelling, and we will be praying for God to extubate, and we may not be able to extubate also. So all these dilemma should be in the pre-anesthesia clinic explained to the patient and husband, because as I told you, they are VVVIPs, and anything you will not explain and will happen to the patient, they will go and complain. And even if they are not VIP, it's the patient right to discuss with him every single possibility. So this was the direct laryngoscopy of the patient. Again, we are still in the pre-anesthesia clinic discussing with the patient and the husband the anesthesia plan or the different anesthesia plans that we can offer her. So what do you think? If you are in a place of the doctor in the pre-anesthesia clinic, so now you will convince the patient that you will give what? According to all those investigations you have. Answers, please.
So far, epidural, CSE, epidural, spinal, general, spinal, epidural, low thoracic, regional, epidural, thoracic, epidural, spinal, combined, spinal, epidural. So it seems that most of the between spinal and the combined spinal epidural.
That's very good. Thank you. Very good. Thank you very much, Dr. Saad. So this is a very good thing. But before we proceed in the slides, would you like my colleagues to prepare your theater for giving regional, and again to prepare your theater for giving this patient GA? Because as we said, we cannot guarantee that we can give the regional, and we don't know what regional we will give. If we try spinal and failed, we can try epidural or what. So now, for this situation, I think we all agree that we should prepare our OR on the day of surgery. We should prepare both, all the facilities for giving this patient regional and all the facilities for giving this patient the GA. So that's what we are going to discuss now. GA, of course, as my colleague said, maybe spinal, maybe combined spinal epidural, or an epidural only. Okay, then let's go. If the patient will do GA, I mean, in case you give spinal or you give regional and it did not work, you will be reverted to GA. What to prepare in the theater? What you will tell your colleagues to prepare in the theater? Answers, please. And we know that she is difficult intubation. She has edema. I mean, what to prepare? I mean, equipments.
All between fiber optic, a small ET tube, and awake fiber optic, gyroscope, a small intracaul tube, difficult intubation trolley, crash trolley, awake fiber optic. Yeah, all of them are in the same direction. Awake fiber optic, ENT to be available, ENT surgeon to be available, video laryngoscopy. So great. Yeah.
Okay, so thank you. That's what we really prepared for her. We prepared video-assisted laryngoscopy, McCoy, laryngoscope, bougie and stylet, and of course, this is a very important and it's a very important medical legal point. We could have the possibility that we intubate this patient if regional failed. We go for general anesthesia and we cannot extubate because of the massive edema of the vocal cords. And that time, this is a very important thing to discuss with the patient and husband in the pre-anesthesia clinic. Yes, it's a possibility, even if 1%, but it is there. It do exist. And then we have to tell the patient and husband about it also, that we may go intubated and we cannot extubate at the end of cesarean section. Okay, if regional, what investigation you would like to have if you are going to plan for regional? Of course, most of us will plan regional first. So what investigation? I know you will say coagulation profile, INR, platelet. I mean, what investigation apart from the routine? Any answers? We discussed it before, early in the lecture. Any answers, Dr. Saad?
MRI, ultrasound, X-ray, spine, ultrasound, neuro assessment, coagulation profile, ultrasound pack, coagulation profile. Yeah, all of them between coagulation profile,
Yeah.
ultrasound, MRI. Thank you.
Yeah, thank you very much, Dr. Saad. Yes, coagulation profile, INR, and plate. And which level and which equipment. To know which level I'm going to enter in, I have to prepare this piece of equipment. This is a very important piece of equipment, ultrasound in the OR. So, because we will do ultrasound in the OR and we'll try to give her the regional ultrasound guided in the OR. Okay? Or, of course, we can tell her we may go for a high-level epidural if we cannot enter the lumbar vertebrae at all. Okay, again, the post-operative plan, we did not finish yet, but I mean, all these things are discussed with the family, the patient and the husband we are still in the pre-anesthesia clinic. Again, the post-operative plan, what we should tell the patient about the post-operative plan, what we will tell, I think we discussed this one. Anyone would like to say something?
Post-op ventilation, difficult extubation, ICU bed, observation, chance of ventilation, ICU, she might be admitted, post-operative ventilation, all of this in the same way. Yeah, post-op ICU.
That's very nice. Thank you, Dr. Saad. Yes, true. We have to tell the patient about this very ugly possibility, but again, we should tell her. So we can discuss her that she will go to ICU, maybe she will go intubated, and she may have, if she will be extubated and have extreme edema in the vocal cords, and she cannot breathe very well, maybe we will extubate, but we have to put her in a very close supervision in a high dependency unit or even in the ICU. So now we came to the day of the OR, the day of surgery. And we will actually go with all these possibilities has been discussed with patient and husband. And now we are in the holding area with the patient, and God help us, all of us. Yeah. And let me tell you that the patient and husband were crying, and the husband was almost collapsed. Yani we were afraid that we will be ending by resuscitating the husband, actually. So patient was reassured in the holding area. She entered the OR with her husband. This was her condition that she will not go to the OR without the husband. Actually, he was the one hugging her and putting her in position when we asked her to sit to start the regional. Regular monitors were attached and a pre-induction vital signs were recorded. They were all within normal limits. Patient was helped to sit. Remember, she is obese and edematous, and the husband was also holding her to sit properly. And of course, he was crying, and we put two nurses with a chair behind him. So if he collapses at any time, they can help him. An ultrasound scanning of the lumbar vertebrae was done. One doctor was doing one anesthesiologist was doing the ultrasound scan while the other was scrubbed to do the block. Unfortunately, all the lumbar intervertebral spaces were undefined or very narrow. We couldn't see one good lumbar space to attempt spinal. And as we discussed before, we cannot, she was screaming that this is her area of pain. She is in chronic back pain. And then we were very much demotivated after the ultrasound scan inside the OR. We were very much demotivated to give her any regional, actually, in the lumbar area. In the lumbar area, we couldn't touch her. So in this, I will stop again. Now we found by ultrasound scanning while the patient is in the OR table that we cannot give any regional in the lumbar area. Any suggestion what we will do? What we will do after that? What is the anesthesia plan? How can we shift our anesthesia plan now?
GA epidural, awake fiber optic, thoracic epidural, awake fiber tab lock, very strange tab lock. Check awake fiber optic, rapid sequence induction, thoracic epidural, awake fiber optic. So between awake fiber optic and higher epidural.
Yeah. Thank you, Dr. Saad. So what actually happened is that we asked her and her husband that we will go a little bit upper. We will go to the lower thoracic intervertebral spaces. We first scanned them by the ultrasound, and we found, fortunately, they were very clearly defined. We were very much motivated to go to the option of regional again. Of course, in this area now, we are in the lower thoracic intervertebral spaces. We cannot give spinal. So the option was sole epidural. We cannot give spinal or combined spinal epidural. So only to give epidural, also by the ultrasound guided. I mean, we scan for the first ear intervertebral space that we can use and put our epidural needle in it. This was discussed again with the husband and her. They know this from previously from the pre-anesthesia clinic, but we assured them that we will leave this area of pain, of chronic pain, because it's almost amalgamated and we'll go a little bit higher. We asked her not to move at all when we asked her, because we will be actually in an area where the spinal cord is there, and we don't want any jerky movement because epidural needle could hit the cord. The epidural anesthesia choice was explained and confirmed to the patient and husband. We choose the first good space as ultrasound documentation. It was T12L1 intervertebral space. It was very well identified by the ultrasound. By the use of a port 6 needle 19 gauge, we introduced an epidural catheter, and it was very easily introduced. God really helped her. It was very easy epidural, and it was advanced cephalid and left inside 5 centimeters inside the epidural space. Patient was asked to sleep on the OR table, and then epidural anesthesia was initiated by shots using plain pipivacaine 0.5%, accompanied with fentanyl to 25 mic. And incremental shots were given until we achieve anesthesia level of T4. And then we asked the obstetrician to start cesarean section. Alhamdulillah, thank God, cesarean section was done uneventfully, and the catheter was left for post-operative analgesia for the patient. In the post-operative period, patient was pain-free, and she was allowed to move early by maintaining a diluted Marcaine with fentanyl epidural continuous infusion. Actually, it was like 0.1% plain Marcaine with 2 mic fentanyl per ml. And we used to run the continuous infusion between 6 to 10 ml per hour to let her feel pain-free and to encourage her to move. She was obese and we were afraid about DVT also. And the obstetrician wanted to move her 6 hours after the accomplishment of cesarean section. So, but of course, we taught her to move attended. She will not be alone, and nurses will help her to go roaming inside her room with this diluted Marcaine infusion. 2 days later, the patient was discharged home with her baby. She was healthy and happy with her newborn baby girl. So thanks God. Again, I think that I remind myself and remind all my colleague anesthesiologists that really it's one of the most exciting and rewarding moments in medicine. And actually, the patient and the husband during the cesarean section and after that in the post-operative, they were having tears from happiness, and they were not believing that she can go uneventful like that. And this was my presentation for you. Thank you very much for your attendance. And if you have any questions, I'm ready. Thank you very much. Thank you, Dr. Saad.
Dr. Esmat, thank you very much for this wonderful interactive presentation. I would like to congratulate Cairo University activity. We have almost challenging now and competing with the mega online course for the number of the attendees. We have inside the webinar 203 people watching your or listening to your wonderful lecture. I will check now. I have a comment of my excellent friend and colleague. He said that the pathway of spinal needle is not affected by the disc herniation because the intervertebral disc of the anterior part and the spinal canal. So there is no problem to give spinal anesthesia at L3-4, isn't right? Dr. Talat Al-Abd from Emirates. The Professor Khalda Radwan is a mega colleague, and she said that with the back condition, regional anesthesia is better to be avoided. I don't know about that. Prof. Esmat might answer this, please.
Yes. Actually, as I told you, the patient was and the husband were actually very much agitated about touching any area of the affected by the previous accident. Because of her chronic back pain, she said to me, even in Arabic, before we go inside, she said, if you couldn't find a very good space, please, by the ultrasound, don't touch my back. I have suffered a long period. She was taking physiotherapy. She was having so many annoying history because of her back. We preferred actually at this moment to avoid, if we could not find a crystal clear space to go in with the spinal needle, we preferred, because it was her request, to avoid touching this complete area. And also because even if we, went away from the lumbar spine, we again can do regional by epidural, going a little bit higher in the thoracic area. And that was also beautiful. So why to insist on spinal while we can hit a prolapsed disc or something that could increase her pain post-operatively, and she will say, I told you, please don't touch my back in this area and put myself in danger. So that's the choice that we choose. It's open for the colleagues to, to try something else. But we believe to respect the patient hopes from us. And we promise her not to touch this area if the ultrasound scan will be not good and we cannot find a crystal clear intervertebral space. And that's what we did.
Um, I don't have any more questions here, to be honest. Um, this I will check now. Um, could not we have given pre-op course of PPI and tested to optimize the general anesthesia circumstances?
Yeah, it was given. Yes, of course. All the routine things in that يعني actually in this institute, all the routine CS preparations and investigations were done to her. Yeah,
Okay.
all the routine was done. But we were so much afraid about in putting a tube in this patient, not because of intubation difficulty only, but because of aggravating the laryngeal and the airway edema. So we may find ourselves trapped. We cannot extubate the patient or extubating and re-intubating from the severe laryngeal edema. So
Okay.
we pray to God that some regional technique will, will work with her, so to avoid the option of GA at all and intubation. Of course, we were lucky because if epidural was patchy or not working, that's the last thing we will revert to. We would give general anesthesia and take our chances. يعني what to do. But alhamdulillah, thanks God, the epidural was very uneventful and it was very easy, by the way, very easy epidural. Alhamdulillah.
Thank you very much, Prof. Esmat. I think we have only one. Oh, wow. You have the top professor here, Walid Hamimi. He is very welcome and he is giving you a very good question. Why didn't you insert the catheter coded in or codal in order to give her epidural steroid post-operative for her back pain? And we know already Prof. Walid Hamimi, he is one of the top star in anesthesia. Very challenging question. Thank you,
Yeah.
Prof.
Ahlan, yeah. Welcome, Walid. Thank you for joining the session. It's very, flattering to me, actually, that you attend. And thank you for your very clever question. Actually, Walid, the consent for the patient and the maneuvers we do for this patient in that institute was not like starting a pain treatment or pain therapy. We were a secondary, not a tertiary hospital, and we were having our limitations. Go for cesarean, give anesthesia, okay, but something to treat post-operative pain, again, her chronic pain condition, no, we did not go far for that. Even, she was only concerned about getting healthy and awake and alive from that one, from the cesarean, and having her baby and postponing everything else. Of course, it's a challenging if we had the opportunity or the approvals that we can do this in that hospital, we would proceed for that, but it was not allowed. There was clear demarcation between giving anesthesia and pain management, and we were only entitled for acute pain management, which is only a post-operative pain management.
Okay, I will take the last question here, Prof. Esmat, if you allow me.
Yes, please.
One of our colleagues is giving us a very challenging question. All of this done while the patient is in elective situation. But what would be done if it is an emergency situation? Really very challenging. Thank you.
Yeah, yes. Yeah, actually, that's why her doctor was, she did not let her to finish to be full term. And that's why we were very much, afraid that she will enter into an emergency situation. But again, I think if I was put in a situation that I meet this patient in emergency cesarean section, I would do again insert an epidural catheter, a high up lower thoracic, as we said, and I will go for the same. I would do the same. In that institute, actually, we used to do for lumbar, normal vaginal delivery, we used to do a combined spinal epidural. We used to give a shot of pipivacaine 2.5 milligram plain with 10 to 25 mic of fentanyl as one shot until the because it works very, very quickly to suppress the uterine contractions pain. And then the patient will be more cooperative. She will give me more time to give her the epidural. So yes, actually, that's what we usually do for the normal patient delivering normally. We usually give combined spinal epidural, starting by giving the spinal. Then when she will subside or the pain of the contraction will start to fade away, we start to fix the caster. But in this patient, of course, we cannot give the spinal portion or the spinal element of the CSE. That's why what we will do, we will go also by the guide of the ultrasound, choose the very next space that's good to work with the epidural, and then we'll do the same. I think I would do the same if I meet her in an emergency situation.
There is another. Okay, we have to stop now because the time and we already passed. So it's all yours now, Prof. Esmat. Thank you very much for your exciting, interactive, informative, very nice lecture about elective difficult situation, challenging for cesarean section with multiple comorbidities. I would like to give you the mic now.